Now let's suppose the patient has appendicitis. What are the treatment options? One is conservative management. This is very important as 70% of the patient having acute appendicitis can be managed conservatively, especially if it is early presentation less than 48 hours. Okay, TLC is less than 18,000, and if the patient has appendiculitis, this type of patient can be managed conservatively, and there is no need to do appendectomy directly. The second option is appendectomy, which can be performed through open or laparoscopically. Mostly we are doing open appendectomy. Open appendectomy, how we will perform open appendectomy? Let's suppose this is patient abdomen lying supine on the OT table. This is the umbilicus, and this is the anterior superior iliac spine. This is spino-umbilical line. Medially two-third and laterally one-third. This is called McBurney's point. This is called McBurney's point. If you are uh, giving great iron incision, which is also called MacArthur's incision or McBurney's incision, these three are all the same. It will be given in such a way that the length of it should be 4 to 8 centimeter length, and one third lies superior to this line and two third lies inferior to this line. This is how we will give the great iron incision. Okay, one is the lens incision. Let's suppose this is umbilicus and this is superior, and this is the McBurney's point. It is a slightly curved incision in such a way that one third lies medially and one third lies laterally and two third lies medially. Okay, these two incisions are differentiated only by the skin incision. Rest of the steps are same in both of these cases. Okay, rest of other options are Rocky Davis incision. This is transverse incision. If the appendix is perforated, then you can give lower midline incision or lower paramedian, lower right paramedian, which was given in the past, but nowadays it is not given. Okay. For example, if you give great iron or lens incision is also known as, this is very important, just remember the name, Bacon's incision. If you give one of these incision to the patient and you are encountering a problem like the appendix is not visualizing, then you extend this incision superolaterally by cutting the muscles. Then this type of incision is called Rutherford Morrison incision. And if there is bleeding and you are searching for the bleeding source, then we will extend this incision medially, which is called Fowler-Wears incision. Okay. Now let's come that you are doing this type of incision. First you will cut the skin, then subcutaneous tissues, then Camper's fascia, Scarpa fascia, then the three muscles. Okay, and lastly preperitoneal fat and then peritoneum. And you reach to the appendix. Reached appendix. Now there are special problem while encountering this uh, appendicitis. One is if the base of the appendix is inflamed, then there are special instruction for this that not crush the base. Usually we crush the base, but in this case, the base should not be crushed, only ligate. Okay. If the base is gangrenous, then no crushing and no ligation. Okay. For example, this is the cecal wall, and the base of the appendix is gangrenous. Then you will take two stitches in the cecal wall and tie this. Okay, this is followed by second layer of seromuscular stitches in the cecum. Okay, this was about um, uh, surgical management of this. And if you are suspecting that the appendix is perforated, in this case, you will give the patient lower midline incision, because in this type of incision you will thoroughly wash the peritoneal cavity. Okay. Okay, thank you. This was about